Good afternoon, friends. Let me welcome all of you on behalf of APPI for this afternoon session. We have a list of eminent speakers today who will be speaking to us on various topics related to quality. I would like to introduce the first speaker. The first speaker is Dr. Selvakumar, who is a very well-known figure. He is a professor and head of clinical chemistry at a famous Christian Medical College in Vellore. Dr. Selvakumar has more than 30 national and international publications to his credit. His laboratory at CMC Vellore is a ISO 1519 that's an enable accredited laboratory which receives a huge number of workload of 4,500 samples and 14,000 tests which are done every day. When we talk of quality control, I guess the first name that comes to mind is Dr. Selvakumar, because he has been running for the past 30 years a EQA program which I'm sure all of us have used in the past. And today he has, there are more than 2,500 laboratories which are enrolling for this program. He holds several administrative posts in Christian Medical College like the Registrar of Academic Affairs, and is also associated with ICMR as an expert in committee to establish reference intervals for the Indian population. Dr. Selvakumar will speak on pre-analytical automation. I would like to invite him and request him to speak. Thank you so much. Would you like, want a mic or a collar mic? Collar mic. So you have half an hour from 2 to 2:30. Thank you.
Thank you, sir, for the introduction. Good afternoon, friends. Today I'm going to talk about the pre-analytical automation and avoiding errors. You know, as laboratory people, we all would have concentrated on the analytical phase of our laboratory. And whenever you think of any instrumentation and when you want to automate, the first question which comes to your mind is, can it repeat? Is it okay?
It's not audible. Can you increase the volume? It's not audible.
The first question which comes to your mind is, when you buy an equipment, can it repay itself? And when you think of pre-analytical automation, many of the administrators and your laboratory bosses will say, this is not income generating, so no way you are going to automate your pre-analytical stage. So today I am going to give arguments why you should automate your pre-analytical phase. We all know that the quality of the lab result that you give depends on the quality of the sample that you receive or the quality of the sample that you take for analysis. If you take a bad quality sample, then the result that you are going to produce, no matter how good you are and how good your analyzers are or how good your techniques are, still you are going to get bad results. So if trash comes into your laboratory, then only trash goes out. So this is where the lab has to look at the pre-analytical state. Now there are a lot of studies which show that there are a lot of there are deaths due to medical errors. They say, there is one study which says 44,000 to 86,000 deaths happen every year, and these are all preventable errors due to medical errors. And this is the 8th leading cause of death. And labs certainly contribute to these deaths indirectly. Why is this? Because the laboratories report incorrect test results, or they delay in notifying the results of abnormal patients and so on. So let's see how we could avoid this. Now if you take the laboratory workload, this again many of you would have seen, and there are a lot of studies which show that the pre-analytical phase takes about 38% of our work. And post-analytical takes about 8%. Transport takes about 4% of our time. Then the chemistry and immuno takes about 15 to 16% of our time. And maintenance takes about 19%, and management meetings and others. This is just a rough estimate how our time in the laboratory is spent. So from this, you can see that pre-analytical phase takes a lot of our time. Now, what are all the activities which could be automated? In the pre-analytical phase, first you can automate the in-lab receipt of notification, specimen triage decisions, centrifugation, uncapping of specimen tubes, loading of tubes to analyze the personality racks, primary tube aliquoting to secondary tubes, labeling and distribution, delivery of specimens to analytical workstations, continuous specimen tracking and retrieval, specimen integrity monitoring, QC rules based review of results for acceptability, and archiving of test samples. So these are all the activities which could be automated. Now, what is the cause of lab errors? If we make errors, then it directly affects the patient care, and I don't have to elaborate on this. And finally, people lose faith in the health system itself, and there is frustration and loss of morale by the lab professionals. So this is where it becomes very, very important that we produce error-free results. Now, if you look at the error distribution, again, there are a number of studies, hundreds of studies. I've just taken the example of 2 studies where the pre-analytical errors range from 46% to 68%. And analytical errors actually is a very small fraction, 7 to 13%, but this is where we all concentrate. And post-analytical errors again range from 47 to 19%. So actually all this show that there is a wrong system in place, but not wrong people. So we don't actually pay more attention to the system, and that is why all these errors are caused. Now, why errors occur in the pre-analytical phase? The pre-analytical phase is a highly complex process. It involves multiple steps, multiple people, and there are numerous tests, many departments, multiple types of specimens, time constraints, no monitoring, and there are very few phlebotomists, and sometimes, very often, the phlebotomist doesn't come under the direct control of the laboratory, and sometimes it involves nurses or doctors. So again, it shows wrong system in place, not wrong people. Now, where do the pre-analytical errors occur? Sometimes a wrong test could have been ordered, but nowadays this is classified as pre-analytical error. The physician who ordered the test itself has made a mistake. He has ordered wrong test. So that is a pre-analytical error. Then comes the sample identification. You identify the sample wrongly. Anticoagulants and preservatives concentration and the ratio is wrongly added. Patient preparation, timing of collection, phlebotomy technique, site, actual draw, delivery, separation and centrifugation, storage and transport. So in all these areas, errors could occur. Now, we all know, whenever we teach our students or whenever we talk to people, we all know that the right coagulation, anticoagulant and the preservative should be added. For example, we all know that spray-dried EDTA is the best for HbA1c, but very often laboratories use still liquid EDTA, and this results in dilution effect. And likewise, there are several errors which can happen in the pre-analytical stage due to the wrong anticoagulant or the preservative. But all this could be avoided by using the pre-evacuated tubes or ready-made tubes where such problems do not occur. So I'm not going to elaborate much in this. And nowadays, a major percentage of the laboratories use pre-evacuated tubes, and any brand, a good quality tube, but again, you have to be careful that there is also an expiry date for all these tubes, and if the expiry date passes, many people argue what can go wrong, but the vacuum can go down, and that can result in drawing lesser sample, which will mean that is the ratio between the anticoagulant and the sample can come down. So you have to be careful in using the right tube. But when you are running a small laboratory, you are always competing with larger laboratories, and they have actually lot of opportunities and options to improve their laboratory service by faster turnaround time, improved consults, better patient education, fewer errors. And that will reduce their costs, eliminate send out costs, reduce labor. So actually, even if you automate your small laboratory or medium sized laboratory, it would make you to stand against the larger laboratories and pay back. Now, who is responsible for the pre-analytical errors? Everybody is responsible, the lab staff, nursing staff, clinicians. And when you look at the laboratory results, if a wrong result is reported, the first person to get blamed is the person who actually does the test. That is the analytical phase. Everybody finds faults with the only person who is actually doing the test, the analytical phase. They are only blamed. But quite often, the error comes from the pre-analytical phase. So it is very difficult to capture where exactly the error occurred, and improper test ordering or sampling for tests, and mostly by nursing staff or phlebotomists, everything gets blamed on the laboratory staff who does the actual test. Now, before we automate a laboratory in the pre-analytical phase, we must understand how the samples come into the lab. There is something called as the peak workload. And this is a study which was done in the Penn State University. And here you can see they have taken different labs where the sample arrival patterns differ from lab to lab, or situation to situation. Here there is a 60% of the samples require centrifugation, 30% of the samples require one aliquot, 70% and 20 and so on. And you can see here the peak, that is the maximum number of samples arrived at this time, whereas in another lab the samples arrived at this time, and so on. So first you must understand, if you want to automate your laboratory, you must understand when do you get the maximum samples. Actually, when we wanted to automate our pre-analytical phase in CMC Vellore, we did a similar study, and we found that around 730 to 8 is our maximum sample load when we get about 5,000 to 6,000 tubes every day. So this is the first requirement for you to think of even automation. Then you must have the right sizing of the laboratory automation. When you think of pre-analytical automation, again, one size fits all doesn't work. For your own lab, you have to choose which is the right automation. So let's see what is good. Now here is a slide which shows an old municipal university affiliated hospital in Japan, where it looks like almost like a manufacturing industry. This is the olden type automation where you find huge machines. But now I know in Mumbai especially there is a big space constraint. You cannot afford to have such large equipments, and you cannot even think of such laboratories. So nowadays, thanks to many of the companies which make smaller type automations, and let's see what are all possible. Now, you have to also think of the cost. So there are three ways you can do it. One is you can think of workstation, where you just automate whatever you want in the pre-analytical phase, or you can go for work cell or total laboratory automation. Now, all this will depend on the number of samples that you receive per year. So if it is say 1 million, then you can settle for workstation. If it is 2 million samples per year, then you go for work cell. Or if it is 3 million or above, then you go for total laboratory automation. And this will relatively increase your cost also. Now, if you look at, again, this is again repetition of my earlier slide. The pre-analytical part is the biggest hands-on area where you do maximum work. It is almost 65% pre and post-analytical area. Then the actual analytical work takes place only about 15%, takes only 15% of our time. And only few labs have automated the pre-analytical area. Supposing you get, say, 1 million tubes in a year. If there is a failure rate of 1%, That means this lab is going to produce 10,000 errors per annum. So that is, something which is frightening. If you are getting about 1 million samples and even 1% error in the pre-analytical area, it will result in 10,000 errors. Then where is your Six Sigma and so on? So you have to think. Then peak workload situations require lot of personnel, thus leading to delays and increasing turnaround time. Now with the accreditation and so on, we all give a turnaround time for many of our tests. So if you want to maintain your turnaround time, then during the peak workload, you have to maintain the constant output of samples from the pre-analytical to the analytical area. So if you look at the patient misidentification, if you do your identification of the patients manually, at least 1 in 2,000 samples we make mistakes if you write the hospital number or identification by hand. And normally we all say that ask the patient to state their full name with initials, compare with the test request form, all this we follow. But when you try to write the hospital number or the ID manually, we all tend to make mistakes. So you can see if you receive 2,000 samples, at least one will be wrong. And we all know that you have to use 2 identification markers and never use room number for identifying. All this we follow. Now, this is again the usual practice that you have to adapt in your laboratory. When you are identifying the patient, you have to label only one sample or one patient at a time. Do not draw extra label tubes and do not simultaneously draw from 2 patients. All this we follow. And there is also this order of draw. Whenever you are using the pre-evacuated tubes, there is an order which you should follow. First you draw in the blood culture tube, then the citrate tube, plain tube without clot activator. So whichever is needed. So even though we teach our students and we try to practice, practically when you want to do it, very often we miss this. Even you get doubts, which tube should I draw first? Or in which tube should I draw for my glycated hemoglobin or for my blood gas analysis? So this is where the automation comes in handy. So if you have an unlabeled sample or mislabeled sample, misalign labels. Some laboratories now print barcoded labels and stick it on the tube, but the major challenge there is when you manually stick these labels, misalignment. When the same tube goes to the analyzers will not read the barcode because it's not aligned properly. Then the technologists tend to print a new label and there again errors can come in. So selection of wrong tubes, long time taken for the patient management. In order to avoid all this, now there is a robo system which is available, but very few labs in India as of now are using it because of the expense. Here, when the doctor orders the test or when the patient pays money for a certain test, the information flows into the robo and immediately it prepares the tubes, it labels barcodes and all that and puts it into these bins. So the patient from the doctor comes and collects his own bin which contains the tubes and goes and sits in front of the phlebotomist and the blood can be drawn. The only disadvantage here is it's a very good system but expensive. It is very, very expensive. Then the other available analyzer is the ATL60, which is actually made by CPC, where the machine is actually located here across the hall. This is an automated selection of tubes as per the LIS patient. Here again, when the doctor orders a test, when the LIS is prepared, the information flows into the the machine, and it prepares the tubes. It affixes the barcode labels in the right patient tubes, and at a time it can dispense 5 tubes in less than 1 minute per patient. And it can hold 24 tubes per segment with 5 different types of tubes. So it has got a loading capacity of 120 tubes, supports commonly available barcodes, and it has got a user-friendly touch screen. And if you want an error-free phlebotomy operation, now ATL is a good solution. Selection of the right tubes, sticking labels properly in correct alignment. That is very, very important because it checks the edge of the label and sticks it in such a way that the rejection rate is very, very minimal. And when you take the primary tube to the analyzer, none of the labels are rejected. So the reprint of labels is avoided, and no change in the workflow, and ensures labels are not sponged. Stat samples have unique identifier to EC identification. So this is the ATL60, which is a very small automation for medium-sized laboratories, which is very, very useful and unique. Once you draw the samples, supposing your lab has got distribution, that is, the lab samples have to go from the phlebotomy site to different labs or different sections. Then there is this instrument called the sorter, HCTS 2000, that is high throughput closed tubes sorter 2000. This is a European instrument. This again, few labs in India have it, and this can actually sort the tubes to various bins, and sorting becomes very, very easy. When I say this, we have experienced this. From the phlebotomy site, when the tubes are sorted, sometimes the tubes will reach a wrong destination. It will go to a wrong laboratory, and if the wrong laboratory doesn't send the tube back to the correct laboratory, it just sits there for hours, which will lead to errors. So this is where this HCT again is a very useful sorter. So it is scalable to different laboratory needs. It can have a throughput of almost 2000 samples per hour for primary tubes, and it can be accelerated using additional support, and it can be connected through your normal net system to your LIS and so on. So it is again a user-friendly sorter which can work in tandem with your ATL. Thereby you get the label tube which can be sorted and sent to the different destination. Then comes that specimen transport. Once from the phlebotomy site the samples are ready, it has to be sorted, transported. Again, we all know certain samples require ice, transport in ice, certain samples require protection from the light and so on. And if you are using pneumatic system, that is a very useful way of transporting samples, but there you have to make sure that the samples don't shake during the transportation. And here is a pneumatic system which we use in CMC, but there are also other pneumatic systems where you put your tubes into these canisters and press the destination. It travels at a very rapid rate and reaches the destination. So wherever your lab is, it will go and reach the laboratory. This kind of pipelines are laid all over the hospital or your lab, and this is where the canisters travel through. Then comes, once the samples reach the laboratory, you need to centrifuge. Again, there are standard procedures that you have to follow for centrifugation. And this, I'm not going to elaborate, but we all know that certain specimens require some additional care. And then once it's centrifuged, you have to separate this plasma or serum as soon as possible. Here again, you have to follow certain rules and regulations. And to do all this, there are now automated systems. And I have just shown the photograph of a standardized automation where you can see there is a loading unit where you load the samples, and there is a buffering unit. Then from there, the samples here are directed to the immunoassay or the chemistry assay, analyzer, or any other analyzer that you want. So here are pre-analytical systems which can do the pre-analytical work efficiently. There are more here, and here again I have shown the pictures of Genesis. This is from Abbott, and here some American system and an Australian system. This is from Beckman, and this is from Roche. And see here again you have total automation from Tecon and WorkCell, Workstation. So you can choose depending upon what kind of workload you have and what all you want to automate. Actually here, this is what we have in CMC Vellore. This is from Roche. Here again you have an input buffer module, automatic centrifuge unit, but we didn't add the centrifuge unit because we were told that can be a bottleneck, but you can have one centrifuge or two centrifuges, and this can be very expensive. And then there's aliquoting module, and you can have de-stopper, barcode label modules, and output buffer modules. So all these analyzers are listed here with their capabilities. I'm not going to go into the details due to time shortage, but if you look at a case study, this was again done in the Milton Hershey Medical Center in USA, and the results were, this is the kind of pre-analytical system they use, including a centrifugation. And here you can see sorting and routine errors, they avoided 80% of the errors. Same way, pour off errors, 80% of the errors were avoided. Labeling errors, 80% were avoided. And biohazard exposure events, 99% of the errors were avoided. So this goes to say that most of the errors could be avoided by using this kind of pre-analytical automation. And the same way, even in coagulation, you can automate and reduce your turnaround time. And you can see if you do it manually, it takes so much time, whereas automated, it takes, avoids a lot of steps. And then there are also robots, but this may not be suitable for India because most of our corridors are crowded, which can transport the samples. And then for molecular diagnostics, to prepare the DNA and RNA samples, you have pre-analytical systems which will cleanly prepare your DNA and RNA and give it to you. And there are also quality indicators. If you are trying to improve your quality of the laboratory, there are a lot of quality indicators suggested by the IFCC working group. And we all know that when you want to maintain your quality of the laboratory, and if you want to improve, you participate in EQUAS programs. Even I was surprised that there are a lot of EQUAS programs for the pre-analytical phase, and here there are several pre-analytical EQUAS programs in which you could participate and improve your laboratory. Even for registration, you have EQUAS programs, and thereby you can improve the quality of your lab. And post-analytical, it's usually sorting and labeling and capping and that's not much of a work, but there are automation available. So why do you want to automate? Is it for cost reduction, process control, or is it image building or error elimination? It could be any one of these reasons or all these reasons. But if you automate, definitely you can bring down your cost of testing, and the testing will be definitely error free. But when you want to automate, the questions that I ask myself, do you have the workload? Is it going to reduce the turnaround time? Is it going to reduce the workforce? Is it going to improve the precision and accuracy? All these questions I ask myself, and then only we automate. So there are a lot of questions you have to ask and choose the right kind of automation. So this is just to illustrate. In CMC, when I joined the lab, we were getting about 150 samples a day. We had 24 technicians. And in 2009, we were getting 4,000 samples a day. Still we had 24 technicians. Today we crossed 6,000. Still we have this 24 technicians. This is only possible because of automation. That doesn't mean that I am against human beings. Normally we say one machine can do the work of 50 ordinary men, but no machine can do the work of one extraordinary man. And who is that extraordinary man? You and me. So if you want to do that extraordinary work, then you have to choose the right automation and run your laboratory error free. Thank you.
Thank you, sir. Thank you very much for a very lucid presentation. We can have one or two questions in case some. Yes.
Hello. I just wanted to ask you, how is pre-analytical EQUAS program run? What does it include?
Actually, most of these are only by documentation. There are several programs for registration of samples. It's done by questionnaires. list, and they also tell you what they do during the program. And for decapping and for everything there are EQUAS programs. So it is not like conventional EQUAS programs that we are used to where a sample is sent to us, but this is all mostly by questionnaires and few things which are very unique and useful. But there are EQUAS programs. ATL 60 cost. Maybe you can see the ATLs across the hall. The machine is there. You can talk to the company and then you can get the price from them. Because I'm not here to canvass for the machine, but the company will tell you what the price is. Workstation is, supposing you want only, say, decapping to be done. Then you can have a workstation. That is that's the lowest form of automation. Work cell is slightly more. You will have 2 or 3 things included in it, and then total automation is everything included. So workstation is the lowest form of automation where you can choose. I want only aliquoting, or I want only labeling, or I want only. So those are called as workstations.
Present a small memento to Dr. Selvakumar.
Thank you.
Thank you so much, sir. So please. Sir, please. I'm sorry, sir, it's not opening.
No, try this.